Okay, good evening, everyone. My name is Abdul Karim Iksayez. I am an investigator for the Research for Health System Strengthening project in northern Syria, which is a project led by King's College London in partnership with the Union for Medical and Relief Organization. And also I'm part of the steering committee of the Syrian Public Health Network. And the Syria Public Health Network with the R4SSS project jointly host this event. And the main objective of this event is to highlight issues related to mental health, specifically in Syria, specifically on two issues, which is substance abuse and self-harm. So we hope that during this event, we will discuss the mental health impact of the Syrian conflict in Syrians, mainly inside Syria, but also we will maybe discuss briefly the impact on Syrian refugees across the world. And also, hopefully, we can explore the prevalence, risk factors, and available health services for mental health, specifically inside Syria. And also, we hope that on the basis of this event, we encourage more conversations and collaborations between mental health professionals and practitioners. Hopefully, this will contribute to a harmonized and locally appropriate approach to address mental health needs. So before the workshop, just a few housekeeping notes. As you see, this is a Zoom meeting, not a webinar. So all of you have the ability to unmute, but please do not unmute yourself unless you speak. And also, if you have questions, please feel free to use the chat, which is at the bottom of your screen. So please use the chat to drop questions for any of the panelists. So the format of today's event will be that we will have four speakers first. Each speaker will have 15 minutes, between 10 to 15 minutes, to present on these two issues of substance abuse and self-harm. And then we will have a moderated session for 1 hour. So the 4 sessions hopefully will be for the first hour of the event. And then we will have a moderated session for almost an hour, chaired by my colleague Diana Reyes. And I encourage all of you to participate actively in this moderated session, because the whole point of this moderated session is not only for the speakers, because we will hear from the speakers in their respective sessions, but the whole idea is to encourage all of you to discuss with each other and also explore your respective experiences. And also if you have recommendations for further collaborations, because we hope that on the basis of this workshop, we will maybe develop a policy briefing on strategies on how to address substance abuse and self-harm in the Syrian context. And this policy briefing could be published in peer-reviewed journals. But more importantly, I hope that we can develop a working group or maybe initiate discussions on these two topics. So without further ado, I will start with the first session. With our first speaker, Professor Mohammed Abu Saleh. And Professor Mohammed Abu Saleh is currently a professor of psychiatry at St. George University of London and a consultant in addiction psychiatry. And Professor Mohammed Abu Saleh was involved in the response, in the mental health response in Syria since the beginning. And he has published extensively on mental health generally, and also he was involved in several research projects related to mental health in Syria. So I hope that Professor Mohammed Abu Saleh will brief us on the issue of substance abuse, what is the available evidence on the prevalence of this issue in Syria, and maybe on the response strategies that have been employed so far in the Syrian response. So over to you, Professor Mohammed. Sorry, Professor Mohammed, you are muted. You can unmute yourself. Okay.
Unmute, yeah. Can you hear me now?
Yes, we can hear you now.
Can you see the slides?
Yes, we can see the slides. Thank you.
Okay. Thank you for the kind invitation, and delighted to be with you. This is an important workshop on a topic that has been thus far quite neglected, really. And I think even much respecting the initiative plus your network to have this workshop. I will time myself. Lest we forget, last month, as I'm sure you all know, was the 11th anniversary of the Syrian conflict, which is still, of course, ongoing and without end, lest we forget. I'm trying to move to, yeah. So I was going to start with a general introduction on substance use disorder and suicidal behavior, then move on to talk about substance use disorder in Syrian populations, look at the evidence on prevalence, response management in conflict setting generally, and in the context of Syria specifically. Substance use disorder, the global burden of disease shows that 20% of the burden of disease of mental disorders is attributed to substance use disorder. 10% for alcohol problems and 10% for a variety of drug problems. There are high rates of what we call diseases of despair. We're talking about advanced liver disease that is almost terminal for people with severe alcoholism, overdoses, mostly for opioids, including medicinal opioids, which are pandemic or epidemics in US and Western Europe. There are so-called accidental overdoses. Some of them are actually disguised suicidal events, but also suicidal behavior per se. Substance use disorders are associated with severe physical and mental comorbidity, high mortality, and for a variety of reasons, besides suicide, because of the serious physical complications of alcohol drug misuse. And it occurs in high deprivation spots in all countries of the world, and associated with serious social harms and criminality in the case of illicit drug use. Diagnosis is quite straightforward and simple, and importantly, it's highly valid. That means it's accurate in terms of what is meant to diagnose, but also highly reliable in terms of agreement between various assessors of mental health who diagnose these conditions. So that makes them the most valid and reliable psychiatric diagnosis. Coming to etiology, it tends to be quite complex, as I'm sure you appreciate, with contribution of genetic and psychosocial factors that occur against the background or a setting of child adversity, family breakdown, and high rates of familial abuse and other traumatic experiences. Importantly, we need to pass the message, be mindful that substance use disorders are treatable and preventable. They are perhaps the most preventable of all mental disorders, whether we're talking about primary prevention, which are public health interventions, secondary selective intervention or early interventions for population at risk, and also those who are with established substance use disorder that required long-term treatment. But also in terms of effectiveness of treatment, there is plenty of evidence for effective treatment for substance use disorder, be they pharmacological and psychosocial. I was asked last year to produce a chapter for this book on preventing suicide and evidence-based approach. And I found that hardly any book of all the books I know of, and I don't, and there's not a single chapter on this topic. So I had to go, of course, to the literature. There's plenty of literature there, but I'm just, for summary, because it's relevant to our discussion or workshop, is that research findings strongly indicate that substance use disorder is a robust risk factor for suicidal behavior. So someone with an alcohol disorder or a drug disorder is 10 times more likely to commit suicide, or also show attempted suicide or parasuicide. And research evidence suggests that there's limited or low quality evidence for effective psychosocial and pharmacology intervention in prevention of suicidal behavior in substance use populations. And in terms of the strategy, I distilled out important elements that primarily includes the key element of training all healthcare practitioners, professionals to assess, detect, and recognize substance use disorder and suicidal risk in all settings, whether in primary care, specialist general hospital, community-based medical or mental health care, or criminal justice system or settings. In terms of the topic of discussion, substance use in Syria and in conflict situations, I found out this systematic review 2016, or 80+ studies, and they found that it was all conducted among refugees, internally displaced populations, asylum seekers, but mostly in high-income settings. And the highest quality prevalence estimates of hazardous or harmful alcohol use range from 17 to 36% in camp setting and 4 to 7% in community settings. There was also actually a study done in Turkey which shows the same. Few studies collected validated measures of illicit drug use, but importantly in terms of correlates or risk factors, 8 studies showed that male sex, trauma exposure, symptoms of mental illness were commonly identified correlates of substance use. In terms of prevalence, there is this survey from WHO, which conduct global surveys, show that there is a high treatment gap for comorbidity, substance use disorder, plus other comorbid conditions, mainly depression. There's a systematic review of research among conflict-affected population reporting alcohol misuse associated with anxiety, depression, and PTSD. I think, needless to say, that all the research being done extensively in Syrian populations show high rates of these conditions, but none of the studies have touched on or screened for substance misuse, but you expect a proportion of them have substance use disorders. In terms of factors such as harmful use of alcohol, male gender again, older age, cumulative trauma, exposure, and depression. There are reports of drug seizures in Turkey. This one refers to seizures of cannabis and phenethylene, Captagon, and heroin. Report 2014 related to the war in Syria. A study was done on prison population inside Syria, identified people with addictions, mostly cannabis and other of Captagon. They draw attention to need for tending to family and peer influence on individual behavior and raise awareness of individuals in the society about drug use education programs, as well as workshops, whether in school, university, and social media. There's this study, which I couldn't find a paper of, from Germany in Hamburg. It was a clinic really for people who use opioids on methadone or replacement treatment like this, showing that quite a few Syrians who were allowed in Germany have opioid disorder, which is quite relatively rare in Syria or the Arab world. Captagon is the main problem and it's been associated with, of course, reports of used by jihadis, ISIS, violence, and so forth, meant to enhance stamina in war situations. The Interior Ministry of Health in Syria reported on 2,000 people with drug use disorder in Syria, mostly young people. I want to draw attention to this Captagon threat, which is available, came out this April, and it shows that Captagon has become a big business in Syria. You can see how many Syrians we have here, but principally, if you look at down there, dots and large-scale production of Captagon around Damascus and Latakia, even Aleppo and other places, mostly state actors producing vast amounts of Captagon and with state actors implicated. And it's smuggled and distributed in all the Arab neighboring countries, including mostly in the Gulf, and Saudi Arabia is a great consumer of these drugs. And also importantly, this is new by sea to North Africa, Libya, and South Europe. You can read this report. It's telling, it means that we're going to have a huge problem with Captagon, which has serious complications, of course, on physical and mental health, can cause psychosis or serious mental disorders. In terms of the UNHCR, again, drawing attention to the lack of services for, I want to speed up this because I've covered it already. There's a study in Germany about qualitative exploration of subsidies among Syrian refugees, identified important themes that refugees coming to Germany that perceive that subsidies are widely available and accepted in Germany, perceive that rules and norms in Germany differ from the rules and norms available in the home country, of course, and needless to go into that. Substance use related to intention to escape the past and related to living in the present, connecting with others and facilitate, integration or bending or, into, German population, and importantly, receiving treatment for substance use is associated with shame. I need to mention the Mental Health Gap Intervention Guide, which is the standard internationally for the enabling non-specialist health workers to assess, diagnose, and even treat mental disorders, that is applied in all around 100 countries in the world, including emergency situations, and it's an important tool to consider when we're talking about interventions. The other important interventions from WHO is the Problem Management Plus, which is started as an individual psychological help for adults with distress, commonly symptoms of anxiety or depression. It's transdiagnostic and could be delivered in group and individual format, 5 sessions, but also can be delivered, facilitated by peer support workers. This has led to its adoption by a Netherlands group called Strength Program. I think Dr. Abu Hilal may mention this. They have a large program funding from the EU to strengthen the healthcare systems for Syrian refugees in Europe and Middle East, integrating these scalable psychological interventions in 8 countries. The other important thing, which I wasn't aware of, is that the alcohol PM plus A basically adapted this intervention to address alcohol issues, and it be tested, interestingly, on refugee populations in Uganda, receiving South Sudan refugees, and Ukraine, of all places. And now it's going to be manualized and tested on various populations. So it's an important addition. It's just been published, and that's important to note and bear in mind when we're providing these scalable intervention. The other one is this called the Stark substance use disorder, developed in Germany. Is meant to be culture-sensitive transdiagnostic group intervention. It's 14 sessions, maybe 10 in groups, quite a novel one, and properly informed by qualitative research involving Syrian refugees to develop this intervention. I have no time to go into detail, but just to highlight it and flag it, that you need to bear in mind that's a single, perhaps most interesting novelty in terms of an intervention that is culture sensitive and adapted to refugees, which is based on sound science and so forth. But of course, 10 sessions, 14 sessions is a quite a demanding intervention. The actual study, I'm not going to go into this, tapped onto the cultural aspects of substance use in Syrian refugees in Europe, which you can read on that time for elaborating. Just a few other things. This is the self-help booklet intervention used by WHO in 2020, doing what matters in times of stress. It's an absolutely superb illustrated guide of 130 pages, which is translated to Arabic and many other languages. And it's actually self-help and very user-friendly. And building on that, the WHO produced the Self-Help Plus, which is a group-based stress management course for adults. Up to 30 people could be attending with recorded sessions but also facilitated by from helpers. They could be actually peers to enable this intervention to have impact. And interestingly, just published in World Psychiatry, the first intervention randomized controlled trial of using this Selfhelp Plus as a preventative intervention in Syrian refugees in Turkey, where half the refugees had this Self Plus intervention and the others are treatment as usual. And what they found, these are distressed, not like people with diagnosable mental disorders, and found that the intervention has reduced the incidence of novel mental disorders by 50%. So that's something to take on board. I think we can skip all these, but I just thought this is a review that may well bring to attention that I did with Dr. Mamoun Bayed, publishing Arab Journal of Psychiatry, quite extensive, actually 10, 15 pages, which I'm happy to send to people, but it's obviously trying to see how we can translate epidemiology research and intervention research to policy and practice, which again is an important consideration. I say, whilst there is growing evidence for effective mental psychosocial support that are integrated to primary care and community mental health services for refugees in neighboring countries, the provision of these services in Syria, particularly the internally displaced, is minimal, unstable, and governed by acute emergency. And optimally displaced Syrian refugees need the provision of sustainable, comprehensive, evidence-based interventions within primary care and mainstream community mental health services and access to institutional care for people experiencing severe mental difficulties. So in conclusion, substance use disorder and self-harm are escalating problems, but are hidden. And Syrian refugees that require more attention, more research. They are treatable, both, because there are means of addressing, suicidal behavior prevention. There's high quality evidence for victims' mental health gap and other cause interventions as listed that we need to bear in mind when considering what is appropriate policy and practice. I end up with this message of hope. Thank you very much. Sorry to 18 minutes.
Thank you very much, Professor Muhammad, and you finished just on time, actually. So we allocated until 2:25 to you. So thank you very much, and really highlighting this important issue of substance abuse. I think all of us, we were hearing a lot of news reports of Captagon threats from the high-scale production of Captagon in Syria, with many incidents, in Italy and in Jordan and Saudi, about Captagon being exported from Syria. And more importantly, I think highlighting some of the solutions and maybe response strategies. And I hope our next speaker will dig in more to talk about local strategies on how to deal with substance abuse and self-harm. So we were supposed to have Dr. Nadim Al-Mushmush as the second speaker.
Sorry, I'm with you. Karim, can you hear me?
Okay, yes, I can hear you. So you are ready, Dr. Nadim?
Unfortunately, my laptop decided to crash at the wrong time. I'm working on it. I've heard all the presentation of Prof. Muhammad. If you don't mind, if the next speaker is ready,
sure,
you can move to that. I'm working on it. Hopefully, it should be ready very soon.
Okay. So and that's why. No worries, Dr. Nadim. That's why we will move to our third speaker. So Dr. Muhammad Abu Hilal, and Dr. Muhammad Abu Hilal is a Syrian psychiatrist, trainer, supervisor, and researcher in mental health. He founded an organization called Syria Bright Future, which is a Syrian organization specialized in the mental health and psychosocial support and protection, and he's very active in this regard. So Dr. Muhammad Abu Hilal, if you could please maybe present.
Can you make me co-host so I can present, or
sure.
I'm able?
I think you are allowed to present.
Okay.
So if you can try share screen. Good. So we can hear you. We can see the screen.
Okay.
So over to you, Dr. Muhammad, please.
Okay. Thank you very much, Dr. Abdelaziz. Abdul Karim, thank you very much for this opportunity and for all other team. Actually, my topic today is field practices related to substance abuse and self-harm in context of Northwest Syria and cross-border humanitarian response. And actually for this, I had communicated with our colleagues inside Syria who are working directly with mental health cases and substance abuse, 2 resident doctors and 1 image gap doctor. And I would like to thank them for the information they gave me so I can prepare for this presentation. And we want only to focus on Northwest Syria, the experience of these doctors and how they see these 2 very important topics, substance abuse and self-harm. For the substance abuse, the most common drugs encountered in the clinics is amphetamine in the shape of Captagon and crystal meth. So this is the most prevalent or common drug that is abused in Northwest Syria. The second one is medication, which is tramadol, especially for injured people who were injured and treated by tramadol, and then they got addicted for it. And also other medication like benzodiazepine and gabapentin and other medication. As per doctors, hashish is like expensive, so usually they don't come to the clinic. And for alcohol, it's very rare in the area. As with the symptoms is presenting to the clinic, Captagon usually when they have withdrawal symptoms of depression, low energy, they come to the clinic. Crystal meth comes with severe psychotic symptoms. Sometimes they need hospitalization. And one case they talked about it is the symptoms lasted for 2 weeks. And also some reports talk about that crystal meth is the cause of very violent crimes that is happening in the area. Tramadol comes with indifference and euphoria when they are taking this medication. Now, for motivation, why they come, actually, the doctors said that the most reason is when these addicts are not able to get the drugs and they enter in the withdrawal stage, they come to clinic to get some medication so they can relieve these symptoms. So there's no genuine actually motivation, but this is the, most common cause for that. Sometimes they are brought by family or police, and the desire for recovery are rare motivation, unfortunately.
Mohammed, can you make this slide slightly bigger in the full screen mode? So, okay. Yes.
Okay.
Perfect. Thank you.
Now, what is the management approach that is used in the area? Most are focusing on dealing with the withdrawal symptoms. Some doctors try to do motivational interviews. They sometimes provide psychological support, so they increase the possibility that the addicts are following the treatment. But there's no comprehensive or qualified cadres to work with these cases for long-term rehabilitation. Some cases, of course, needs detoxification. So they are not treated in the mental health hospital. They refer to private hospitals. And sometimes if the family is caring and there's good environment in the home, they can treat them on home-based approach. They mentioned that there was one center in Idlib to deal with the substance abuse, but was closed because of funding, lack of funding. Self-harm in drug abusers, they hurt themselves to increase the euphoria, so they cut their skins, or sometimes when they are in withdrawal symptoms, they feel in depression and they cut their skins to relieve their pain. Now, for suicide and self-harm in general, recently there was increased interest on this area, and in the technical working group, mental health technical working group for Northwest Syria, there was a task force specialized for suicide and self-harm to follow and do statistics and raise awareness and do trainings on that. So this is like recently is got interest. And one doctor said that there's a real increase in the suicide and self-harm. For example, he mentioned about one MHK doctor who got two cases of suicide attempts at one night. So that's an alarming sign. And also, I mean, doctors has emphasized, and this is very important, that the real numbers of suicide is very difficult actually to quantify, because of cultural barriers and many other barriers that are there. So this is a challenge for research, actually. Causes for self-harm and suicide attempts, two main reasons mentioned are, one is to draw attention from people around when the person is under pressure. And so these people, when I refer to psychosocial support, they don't follow with the sessions. So as if it is only to attract attention. Now, the most important factor is poor condition, living conditions. And this was emphasized by all the doctors I talked with, is poor living conditions are responsible, as they said, for 90% of suicide attempts. So it is not depression, not other causes, it is like poor living conditions. So this signifies the importance of holistic approach of the problem. Some brief cases. First case, a female had severe depression and lack of basic needs. She needed, actually, she thought to sell her kidney to improve her living conditions. Doctors tried to help her clinically. She committed for a while, but then she quit and tried to hurt herself several times over a period of 2 years. Then, unfortunately, she had a complete suicide. Second case, she had an obsessive compulsive disorder and depression, and the supportive environment for her was very bad, but there was good medical help by medication, but unfortunately, she committed suicide as well. And third case is pure depression. He is a pharmacist. His financial condition was good. His family was supportive, but his depression was very severe and he committed suicide with a gunshot. Change of attitudes of people about substance abuse and self-harm and suicide. Substance abuse become common and reality. However, still people don't accept it. And one said that I refuse to marry my daughter for a date. So this is actually still culture, don't accept this. The efforts of volunteers, teams, and organization succeeded in raising the awareness about the issue. For suicide, the community awareness has increased and become acceptable by faith leaders to talk about it. And also cases are more open to talk and discuss this issue with their doctors. Now, the recommendation from the doctors is, this is interesting, supporting the factors that increase the price of drugs. They talked about when these drugs and substances became like expensive, so they saw more patients came to clinics to get the treatments. So if there's any factors that increase these prices or prevent these substances from entering the area, we think that more people will come to get the treatment. Of course, we need to establish specialized hospitals or centers for treatment of addiction, and also securing job opportunity for youth, because unemployment is one of the main causes actually for people to go and use these drugs. For suicide, we need to securing psychiatric drugs in both in quantity and quality. They said even if a patient has money, right, there's no availability of certain drugs or new drugs that is suitable for their cases. So this is important. And also to prevent suicide, we need to work on improving the bad living conditions and securing people's basic needs, because it is their absence that causes great pressure on them and cause them for depression. So lastly, I want to talk about the situation of mental health system in Syria, in northwest Syria. So I can say my recommendation. Unfortunately, most of the projects are short-term, usually for 1 year. There's lack of localization, so projects are donor-driven. There's lack of cultural adaptation efforts, lack of evaluation of the project impacts, so no lesson learned or adjustment were made for strategic planning, lack of evaluation of cost effectiveness of the projects and interventions. And we are under threat of low resources now if the cross-border will be closed. So we need to think about what is the best to do with our small resources that are shrinking. And no effective coordination within the sector and with other sector services are usually disconnected and inconsistent. I mean, in the technical working group, we're trying hard. We started to send representatives to other sectors to coordinate about mental health and psychosocial support, but still there's a lot to long to go actually to improve the coordination in mental health. And also the last thing is researchers are not coordinated. Sometimes we get results that contradictory and no solid plans of uptake. So there's a lot of research, but it is difficult, no uptake or use of this in programming. So this is like, in general, some aspect of current mental health system. So my recommendation actually, and this is related to, I think, your work, Dr. Abdul Karim and others, is the only way that I see to respond to substance abuse and suicide for Syrians is to take a system thinking approach to understand the mental health system and the wider system that we are living in. These are not clinical problems. These are a complex, multi-dimensional problems that need to be understood fully and engage all stakeholders. So we need to understand this system, and then we can plan for best intervention that is appropriate, effective, efficient, and sustainable. Thank you very much for your listening and this opportunity. Thank you.
Thank you very much, Dr. Muhammad. Really great presentation and very linked to the realities on the ground. And as you said, it's not a simple problem. It's not only a clinical problem. It does require a system thinking approach. And I think after 10 years of the conflict, it is time now to think about a more systematic approach, not only short-term and life-saving only solutions. We need to think about strengthening systems. And hopefully that, as you mentioned, this is very relevant to the work we do in the Research for Health System Strengthening in Northern Syria project. So I hope that we can explore collaboration opportunities further in the area of mental health. So, and now we move to our third speaker, Dr. Nadim Al-Mishmish. And Dr. Nadim hopefully will talk to us about self-harm specifically. So we heard from Professor Muhammad Abu Saleh about available evidence on substance abuse. So we will hear from Dr. Nadim about self-harm. I remember, I think in 2016 or 17, when Idlib Health Directorate, they issued a statement on suicide in Idlib. I think this was the first statement of its kind, and it was perceived with a lot of negativity that this is not a problem in the region, and it's not a priority to talk about suicide, while it was, and it's proved to be a priority in the following years. I think there was a report by Save the Children just last April in 2021 talking about an increase of about 80%. Or maybe 86% of self-harm incidents in northwest of Syria. So over to Dr. Nadim, and Dr. Nadim is a consultant psychiatrist, and he is a founding member of the Syrian Association for Mental Health, SAMH, and also he's been very active in the mental health response in Syria since the beginning. So over to you, Dr. Nadim.
Thank you, Karim. Thank you. I hope everyone can hear me okay.
We can hear you very good, yes.
And
we can see the
slides. Great.
Yes.
I'm really sorry about the earlier glitch on my laptop. It's just decided to crash at the wrong time.
Can you make the slide bigger? I'm sorry to do the presentation mode.
Sure. Let's see that.
Maybe down the little on the right. Yes, here you go. Thank you.
That better?
Yes, much better.
Right. Okay, sorry. Right. I did hear both presentation, both Prof. Saleh and Dr. Walal. So my presentation, I tried just to be as brief because of the limitation of time, particularly on this very complex subject of self-harm and suicide. So thanks for the introduction and for the opportunity. It's great to meet up with colleagues who are interested in the Syrian kind of conflict and situation. Mental health is an important subject, and thanks for the organizers to bring people together to highlight the issues of self-harm and also substance misuse. So if I quickly just talk about the deliberate self-harm, both in general, and we go towards what's happening in Syria and refugees and also inside Syria. So it's quite a common problem, deliberate self-harm in young people, and in a systematic review, in multi-systematic reviews and research, it shows that it's about 13% of young people have self-harmed in the previous 12 months. So it's quite a big issue and quite common. Most reasons given is relief from distressing thoughts or emotions, and risk factors included, as you might imagine, past trauma and abuse, anxiety, depression, and other negative emotions and experiences. The most common method of self-harm used by youngsters are cutting by using sharp items. And it does help, as I think Dr. Walal mentioned, to regulate tension inside, or anxiety or anger, particularly for those who are unable to regulate their emotions. It is a very high risk factors when it comes to suicide. For those who self-harm, it does increase the likelihood of an individual committing suicide by 50 to 100 folds. So it's not something to be dismissed lightly. Then if we just move on to what's happening for refugees and asylum seekers, again in a systematic review by Garriello in 2001, self-harming behavior in asylum seekers and refugees. It shows that this subject is not fully studied and developed and disorganized, but it does also highlight the issues that unaccompanied minors are quite a vulnerable group, vulnerable category, and also those who are in detention centers have a much higher risk of self-harming behavior. So that's in general for all asylum seekers and refugees. If we want to touch on what's happening in regard to Syrians, in one big study done by Vrock in 2018 rather, included about over 120 Syrians and Afghan minors. It shows there's no difference in terms of deliberate self-harm prevalence and also the methods used. So it's quite comparable to Western adolescents. Suicides in those displaced people in general, again, a systematic review done by Kugo in 2021. It shows that the evidence base for studies done in refugees and asylum for asylum seekers are still scarce, but it does also recommend that despite the scarcity of studies, there is evidence that there is high risk of suicide and suicidal behavior among refugees in camps and asylum seekers, which is a significant kind of observation. It also suggests that there is a need to additional support and monitoring of this particular group, particularly those who still in the asylum seeking process, which in itself can cause lots of uncertainties for lots of people, particularly if their cause has not been answered or if application is not being processed. And so those groups are high risk group. I'm not sure if this has been mentioned, but if we move closer to Syria and northwest Syria, there is this reports, it's quite worrying reports, produced by Save the Children in 2021. It records the number of suicides completed in people who live in northwest Syria, I think in Idlib province and surrounding area. And it's quite a large number, 246 completed suicide and about over 1,700 attempted suicide. The most worrying part is that about 1/5 of these are young people. So it's quite a vulnerable group of people, teenagers. But for I think the majority of those tests recorded by suicide involve people who are displaced from their homes. For those who don't know northwest Syria, obviously there are the original people who were there before the conflict, and there are I think about a couple of millions who end up being internally displaced inside that corner of northwest Syria. So majority of this by suicide seems to be completed by those who are displaced rather than those who are original. But that's not to say that those who already live there don't have the risk, because the situation there applies to all of them. The economic kind of deterioration, the unemployment, the stress, the ongoing conflict that's happening in the rest of the country. So it is a worrying trend that need to be aware of. Of course, there are the many more cases maybe go unreported for various reasons, including cultural, religious aspects, and also the fear of stigma. Suicide inside Syria, there aren't many research or studies done, but we could take a look at what the WHO and World Bank figures provide, which are quite crude rates of suicide. It does show that there are about 2 suicides per 100,000 population in 2019, which is an increase from the 2011. There is an increasing trend. There are steady figures for females, so female suicide seems to be the same figure between 2011 and 19. However, it's higher for male, by 4 and 5 times. It's not clear what are the causes of these, whether they are mental health problems, whether they are terminal illnesses that might be the reason for why so many people end up committing suicide in other parts of the world, or whether it's the ongoing conflict of Syria. But having said this, if you look at the figures of suicide for the rest of the world, Syria seems to be in the lower 10 of the list of those suicides, despite it being obviously in the increase, which not to be dismissed. What can be done? Right. Obviously, it goes without saying, prevention is better than cure, but it's easier said than done. Because of suicide is quite complex issues, quite complex phenomena, and with complex etiology. So we need to go beyond what's possible individual risk factors to more broader factors on what's contributing to this problem. And despite many studies being done even in the most developed countries, suicide is still a very kind of difficult area to try and prevent and stop. So obviously we could improve ourselves by improving our assessment into asking the question about suicide, and because evidence shows that asking about suicide increase the likelihood of discovering suicide thinking by at least 7 times. And the research done on children and adolescents showed that those who have suicidal behavior, they felt better for being asked. So we shouldn't kind of shy away from asking the question about whether an individual that we're seeing have suicidal behaviors or have been involved, have suicidal thinking, or whether they've been involved in suicidal behaviors in the past. So studies done, again, it's sparse, not very productive, but in a systematic review done by Rus in 2018 on the evidence of suicide prevention response program with refugees, they identified about 8 programs that have been implemented with refugees. The outcome of these were quite weak when it comes to the study designs, but they did highlight that a couple of those programs were done specifically on populations who are displaced, and they highlight the need for training of health workers to recognize the problem, and mainly awareness raising rather than any particular kind of intervention that any of these studies highlighted. So it's still an area that's not well researched still. They did, however, kind of suggest that a multi-tier approach might be appropriate to adopt, particularly taking into consideration what colleagues, I'm sure colleagues in public health are fully aware of such model of public health model of including surveillance and reporting centers that could be in primary care, maybe in schools, to report those cases. And as we start reporting, we identify what the risk factors might be behind them, and then we develop appropriate programs based on those information that we get. And of course, there will be a need for ongoing monitoring and evaluating of such programs. Of course, this needs to be done at multi-level. Not sure how I'm doing with time because I haven't looked at the time. Am I okay still?
2 minutes.
Oh, okay. Right. So I think it's important.
Maybe.
Thank you, Kareem, very generosity. Yeah, it's quite a complex subject. I think I'll have to rush to just to conclude the last two, three slides. So prevention, obviously, is need to start from scratch. Schools are an important area for youngsters to start with because it's convenient, natural location for them, excellent reach, opportunity to reduce stigma. So we could use what's been used in other parts of the world, a particular strategy or approach called QPR, question, persuade, and refer. But for that to happen, you need to obviously make front staff, school teachers aware of what it is and be educated and to ask the question and then move forward. There is we could make good use of the Royal College Psychiatrist Guide for school staff. This I think might be something that we can focus on, maybe translate to Arabic because quite a good guide. The CASP intervention, which is the contact and safe plan. This is being tried and researched by Vijay Kumar in 2017 in a population in camps. Refugees in camps with good results. It talks about generating safety plan or a document to identify individual risk and what those individuals need to be supported with and referred if needed. Management of self-harm is quite complex. I think colleagues already mentioned about what can be of help, particularly at large scale, including the use of mental health gap. And also primary care staff to recognize and refer cases, the need for capacity building to use possible external resources, particularly those who might be willing to volunteer for help, but they are outside Syria. An example that we've done good work on the telemental health done by the Syrian Telemental Health Network, which I took part and quite a few colleagues on the meeting today has participated to good effect. There is a reference to it at the end. The power of the whip, of course, it could be a double-edged sword, could be used for negative or positive, but I think that can be optimized as well to see what's available in terms of good evidence to support youngsters and use of apps to move them forward and reduce the risk. In summary, this is the last slide. We recognize out of this quick review that the deliberate self-harm youth is quite common, including Syrian refugees. They're not an exception. Suicide has complex etiology, but there are sparse research evidence into the prevalence in refugees. Refugees in camps and asylum seekers are at increased risk. There are worrying trends coming from northwest Syria of prevalence of suicide that need to be monitored maybe or observed in the coming years, the coming periods. Deliberate self-harm increase the risk of suicide at individual level. Our duty is to try and raise awareness and train frontline staff. There is a program of QPR that I mentioned earlier. There's further utilization of the mental health gap program and use of telemental health, and also, of course, the benefits of using the safety plan for individuals at risk. And this is my contributions of the last few years on working with mental health refugees and what I have done. And that's the end of my slides, and thank you very much.
Thank you very much, Dr. Nadim. A great presentation, actually highlighting the complexity of the issue of deliberate self-harm. And as all the presenters mentioned, we need interventions on all levels. Starting from families, schools, and community, and also clinical interventions. And I think this maybe gives a further importance to our fourth speaker, Dr. Ala Al-Khani, who will discuss family interventions that can be designed to help to address these two issues, substance abuse and self-harm. So Dr. Ala Al-Khani, our fourth speaker, is a humanitarian psychologist, and she works as a consultant with several international organizations, including the United Nations Office on Drugs and Crime. And she's also a research associate at the University of Manchester. So she was involved in delivering trainings and designing interventions, family interventions in more than 20 countries. So Dr. Ala, over to you, please.
Thank you so much. Can I share my screen, please, Dr. Nadim? I think you have to, yeah.
Yeah, so Dr. Nadim, if you can stop, please, sharing your screen. So Dr. Ala can go. Yes.
Thank you very much. Okay, super. Can you all see my screen?
Yes, we can, and we can hear you clearly.
Great, thank you. Okay, and you can see the presenter view, is that right?
Yes.
Okay, great. Well, thank you to the organizers for this really important topic and for the great contributions of the speakers before me. It's a really important topic to discuss, and it's so timely that it's come now as well. So I hope in this presentation to approach today's theme of discussion from a prevention rather than a treatment lens. And this is really drawing again on the implications of Dr. Abu Hilal on looking at this topic from a very multidimensional approach. I hope to provide you with examples from the field on how utilizing family skills interventions is really key to preventing a number of psychosocial, emotional, and mental health issues as well. I'm going to be showing you examples of how we do this in the Syrian context as well. So in discussions on Syria's mental health crisis, it's really hard not to feel frustrated at the lack of opportunities to intervene with essential programming. But what I hope to do here is demonstrate that there are many ways that we can chip at the mental health crisis when we begin to prioritize supporting the caregivers in the way that they care for their children. Let me start by sharing with you an image of our UNODC International Standards of Drug Use Prevention. The reason I'm mentioning the standards here, and only briefly, usually we have a 3-day complete training of the standards, is that there's a science behind prevention. Essentially, what this means is that there is no need for us to improvise in terms of what programs work and what programs don't work in terms of initiation of substance abuse and other risky behaviors. The other key message is that prevention is much more than just awareness of drugs or the risks of self-harm, for example. We're moving away now from this awareness fear-raising. We're far beyond this strategy now globally, and we hope now as we approach the Syrian crisis with this topic as well. Messages of say no to drugs assume that at a very young age of vulnerability, there's some kind of free, independent choice that the child or the youth can make to say yes or no, without really recognizing the rest of the vulnerabilities that are surrounding the child. So the point of focus is shifted from the substance use or the risky behaviors from being the problem to actually how can we help that individual in the different stages and ages of their development to grow in a really healthy and safe way. So this is the main vulnerability framework that we work on, and we recognize that every person has their own personal characteristics, and each person will live in a different context in terms of the microstructure around them, and in terms of the way that they interact with their family, the way their family interacts with them, school, peer pressure, and all the other things that are surrounding each individual. And these microstructures are embedded further into an even larger structure. And there are specific programs that will help every child address their own social and emotional needs and the structures around them that can support their individual resilience to grow in a good way. It can be a surprise often to us and to policymakers that some substance use prevention interventions can actually happen prenatally, so before a child is even born, as well as very early on in their life, also early adolescence. So really working very early on to prevent substance use prevention much later on in the future. What we know from science is that the earlier we intervene, the better are the outcomes. We are preventing risky behaviors in the context of substance abuse, but also so many other health and social consequences too, like improved mental health, improved educational attainment, and a reduction in violence against children. Prevention work heavily focuses on the family. The family is a social institution that is incredibly powerful in the lives of children, and we can all recognize and agree on that together. These are people that we have shared genes with, shared history, daily experiences, and a future as well. And we very often underestimate the role of the family in prevention work, though it's incredibly important. The relationship that the parents or the primary caregivers have with their children can be the primary most important factor in their future well-being. But what about during refugee or conflict contexts? Well, this is only even further magnified. But despite all of the potential protective factors that parents can be in this context, research tells us that children raised in families that have experienced conflict are far more likely to experience really heavy, violent discipline, as well as emotionally unresponsive parenting. We know that children living through conflict can be protected by warm, secure parenting, yet parenting support is often always ignored in the cycle of care for families in humanitarian contexts. Another reason for supporting families as well is that supporting families is a prevention strategy that is really cost effective. Research tells us that we have a really high return. For every dollar we spend in prevention, we get almost a $10 return when we use family skills programs. So myself and colleagues at the University of Manchester conducted field research in refugee camps in Syria and in Turkey, really trying to understand as a starting point what challenges caregivers were facing in caring for their children. And we found that caregivers were massively struggling in parenting. There were tough environmental conditions like a lack of resources, struggles for basic needs, watching children change in their emotions and their behaviors, caregivers themselves being massively overloaded, having anxiety, a lack of control for the context they were living in, and them not knowing where to get support from. Parents told us that they were making significant attempts at accessing support on information of how to look after their children, but there simply was none available. Child psychosocial recovery interventions in humanitarian contexts like Syria simply overlook the significant effect that parents can have on improving their children's future outcomes. So I've mentioned the term family skills programs a few times now, but what exactly are they? So children don't come with manuals. We can all agree on that, particularly those of us who are parents. all families in all contexts can really benefit from family skills programs and resources that aim to strengthen family protective factors like conflict resolution, like the importance of listening and communicating, ways to encourage positive behavior, ways to discourage misbehavior. We can agree that in terms of conflict and refugee context, families need now more than ever for their children to be listening to them and to be following their safety instructions. Families that take part in family skills programs are far more likely to have better mental health, physical and social outcomes in the future, and their children are far more likely to not initiate drug use and other risky behaviors. The importance of these programs has been extensively documented, but we're still not seeing enough efforts to make family skills programs available in war and refugee contexts. And there are many reasons why. A few of them were mentioned by the previous speakers. We've just had a communication piece published on this. And for those of you who are interested, you can have a look at this later on. So in response to the identified gap that we found in a lack of family skills resources in the Syrian response, despite there being clearly much need, colleagues and I have been developing and implementing family skills open resource information that can be accessible to meet this need. We've developed this model of multi-level parenting support delivery for families living in war and refugee contexts. And this you will see maps well against the MHPSS model of psychosocial support, where at every level, families can be provided with family skills support, depending on how much resources the area they're living in has and how much need there is. Though we work at every level and we have resources open access that you can all have access to, I'm only going to touch briefly on 3 of these for the sake of time. Just to note, in all of these resources, we do not mention the term drugs or substance use or self-harm. These words are not mentioned at all. Rather, what we do is build on the family protective components that cause a direct causal relationship with the prevention of drug initiation and other risky behaviors by promoting resilience and better mental health. So from our research, we recognize that all families could benefit from basic parenting information. So the bottom level here in our model in yellow is efforts to provide very basic information on a universal level to families through the development and the distribution of a parenting information leaflet that we initially distributed in a conflict zone inside Syria at the height of the Syrian conflict. In our published trial, the Bread Wrapper study, we posted 3,000 of these urgent parenting information leaflets and also feedback questionnaires to families living in Aleppo via a bread bakery. Leaflets were explaining the different types of behavior that children might be experiencing and helpful tips on providing, for example, warmth, safety, giving praise, spending time together, trying to maintain some kind of routine. And these leaflets and these pens were wrapped inside the packaging of bread and delivered by an NGO. Of the 3,000 leaflets that we sent out and the questionnaires, we had an astonishing 60% response rate returned by the caregivers. Any researcher here will tell you that a 60% response rate is really impressive, let alone in a conflict zone inside Syria through the height of the Syrian conflict. Of the 80% of the internally displaced Syrians, they rated the overall usefulness of the leaflet as quite a lot or a great deal, and they left hundreds of comments on how they wanted much more intensive information on how to care for their children. These leaflets are now being used extensively and over the last few years in the refugee European context, and more recently in the Ukraine context. We've distributed hundreds of thousands of these in the last few weeks alone across the European borders. We've also used this method of light touch universal information on parenting in the COVID-19 context, developing specific parenting information such as booklets and parenting leaflets for families facing the pandemic in IDP and refugee contexts in North Syria, really recognizing how important it is to have tailored information for the refugee context. So back to our model, what about information for or interventions for children who need more specific trauma recovery support due to war exposure and require trauma recovery intervention? So right at the tip of our model, the complete opposite of the universal information, what can we do for those children? So we've been working with the Children and War Foundation. I'm sure many of you are familiar with their work, to enhance their existing Teaching Recovery Techniques program, which is an evidence-based child trauma recovery program that's being used globally. The original program is for children that score high on trauma measures. What we did was include a complete new stream of this program of family parenting sessions tailored on our research in Syria. So while the children are engaging in trauma recovery work, their caregivers are taking part in evidence-based family skills programs as well. We conducted a trial of this along the Syria-Turkey border with Syrian refugees, with really promising outcomes of significant improvements, child behavior and family functioning, in child and caregiver mental health, and in their well-being. We then went on, encouraged by this, to do another randomized control trial with Syrian refugees living in the Bekaa Valley. And again, we found that those families that took part in the enhanced version, so when the children took part in trauma recovery work, but their caregivers also improved their parenting, this group had the highest positive effects on children's outcomes. If we go back to our model now, we've addressed the parenting needs and supports at the universal level and at the real tip of the model. But what about families who really sit in the middle of this model? Those such as families in Syrian IDP camps in North Syria that have accumulated years of emotional and behavioral challenges, and that could be greatly supported by family skills interventions. Well, we worked with Chemonix International, who work heavily in Northeast Syria on PSS programming, and I worked with them to develop an evidence-informed child trauma and psychosocial program called Better Together. And as you can see from this program, we look at things like emotional regulation, emotional recognition, problem solving, communication, working on managing stress, reducing intrusive thoughts and behaviors. And this has been really important in the context of North Syria. Key features of this program are, as you can see, it's light, requiring an infrastructure that's really easy to mobilize and train. And that training is aimed at lay people from different backgrounds. And this is something that we look at that is very important when we talk about mental health support in the context of Syria, is having these light touch programs. And sessions are for both children and caregivers. You can see from the imagery that it's really light, and any documents that the caregivers will receive rely heavily on images and on icons. We initially piloted this in Deir ez-Zor, Northeast Syria, in a formal IDP camp, and we had really promising results. And we've just completed another round of programming with 400 IDP families in the same area in Syria. I'm only going to touch on this briefly for time. I think I have 2 minutes left, but our results have indicated decreases in intrusive thoughts in children by almost 63%. We found really significant decreases in children's sleep disturbances, significant decreases in families using physical violence in their children, and significant improvements in the mental health of children. So in summary, we really need to make use of this really wonderful protective shield that caregivers can be for their children during conflict and refugee contexts. And we can do this by ensuring access to family skills resources. The earlier we reach families with family skills support, the less likely we are going to need to support later on in terms of mental health and social outcomes. We know that family skills programs can be delivered even in challenging contexts like the Syrian context, but there's a need to make resources light and have flexible approaches to both training and delivery. And when we do this, we reduce the likelihood of the link between conflict and the negative effects of children and their caregivers. There's a link here of where you can access all of the resources that I've mentioned, and they're all open access, and I'll put them in the chat of this meeting as well. Thank you for your attention.
Thank you very much, Dr. Ala, and thank you for all our presenters. And in the interest of time, we will move now to our moderated session. And it's good that Dr. Ala gave us some hopes that we can still do things. Over to you, to my colleague, Diana, please.
Thank you, Karim, and utmost thanks to our speakers. I think we should take a moment to acknowledge that these are important, but also very heavy and challenging topics. So I would like to take a moment just to thank our speakers, acknowledge the importance of your work and contributions to the field of global mental health, which have certainly touched and inspired many, including myself. So as a means of introducing myself, I'm Diana Reyes. I'm a PhD student at the Johns Hopkins Bloomberg School of Public Health in the Department of International Health, where I'm studying social and behavioral interventions to improve the mental health of refugees and migrants. I'm also a steering committee member of the Syrian Public Health Network and have contributed to research in various capacities on the health impacts of the Syrian conflict. So to bring us into our moderated discussion, and we're very much looking forward to your questions and comments, including in Arabic. So if those who want to speak or communicate in Arabic, please feel free to do so. We want to reflect now on some of the ways forward, so solutions and potential opportunities to addressing the conditions of substance abuse and self-harm that we've discussed extensively with the support of our expert speakers. So we have an expert panel who will be joining us, and I think who I see present here is Dr. Andres Barkil Oteo, Dr. Nidal Sadon, and we're hoping to be joined by also Bashir al-Haj Hussein, Dr. Masa Kurdi, and Dr. Radwan al-Khayyat. And I'll ask you all to comment on these critical issues based on your clinical and field experience. And to take advantage of the little time we have, I will not introduce each of you specifically, but hope you can just provide a quick introduction as you respond to some of the questions. So I will open it to the chat or the audience to go ahead and ask the first question. If there's anyone who's interested in commenting on something that was brought up previously. And if not, I have a question to prompt us all. So, all right, I see a hand from Salah. Please, Salah.
Hello, everyone. Thanks, Diana. Can you hear me?
Yes, can hear you.
Yes, this is Salahuddin Ligge. I'm a Syrian psychologist based in Gaziantep, and I am the MHPS specialist in one Syrian organization. Our response is in Northwest Syria in general, and also the member of MHPS Technical Working Group for Northwest Syria. I would like to comment about the suicide that presented by Dr. Nadim al-Mishwash. Actually, we have a lot of, in the last 2 years, I think, we have a lot of, let's say, confusion and misinterpretation about the suicide situation in Northwest Syria. All of this is based on, let's say, survey conducted in 2019 and 22 in Northwest Syria by Syrian MHPS organization and by Syrian Health Organization under the supervision of, let's say, technical working group in Northwest Syria. It was just survey, but after that, a lot of, let's say, international NGO and, let's say, social and media agency published that, let's say, surveys that give that survey, let's say, a lot of, how can I say it? It is became like study or research, but it was not like that. It is just survey to see the situation in Northwest Syria, and Dr. Nidal and Bishar and me and a lot of specialists was part of that survey. The goal of that survey was just to know about the situation. But actually, to be honest with all of you, there is let's say limitation about that survey. At least it's not, for example, focus group discussion. It was not qualitative research. It's just survey. Every health worker can respond to that survey, and there is a lot of duplication in the response. So I think we need to be. I think we need to put this into consideration. It was very important to have that survey in Northwest Syria, but it's also very important to know more deeply about the suicide situation in Northwest Syria. That's what I would like to comment. And I think Bishar and Dr. Nidal can talk about the numbers that we have right now. For example, in last quarter, there's, I think, 10 suicide attempts, people who die as a result of suicide. And if we go back to the old statistic that we have it in Northwest Syria, we will not find that we have 250 suicide person died as a result of suicide. So we need to put all of these statistics together to know the situation and to do more to understand the situation also related to the mental health and suicide. Thanks, Tiana.
Thank you very much, Salah. And I'll hand it over to Dr. Abu Hilal to respond.
Yeah, actually, thank you, Salah, for this. Actually, I want to raise this issue. First, I'm proud that this conference is organized mostly by Syrians for Syrian issue. And this is actually something new because usually somebody expert from outside comes to organize things for us. So I'm very enthusiastic about this conference actually. Now, the problem of studies and how it's interpreted or presented is not only for suicide. It is for almost all the statistics that is common about the mental health problems. Even actually in the brief that was shared before the meeting, like when somebody talk about 70% of PTSD, right? This cannot be acceptable, right? So what they do is they measure some symptoms, right? Then by editing, somebody take from another resources, it becomes that this number of people has PTSD. Now, actually, all of us has nightmares. We have other symptoms, right? But this is not PTSD. So this is actually a very important issue and cannot be solved unless we, again, take a holistic approach to discuss all the literature and see actually what's really more correct, if we can say, or not. So we need to challenge these studies against each other and also to ask people on the ground how they see these things. Thank you very much.
Thank you, Dr. Abu Hilal. I think Dr. Nadeem would like to respond as well.
Yes, no, thank you. Thank you, Salah, for raising this. Obviously, Arabic al-ahd ala al-rawi. So this is why we put the save the children as the one who reported this. I always take, these kind of figures with lots of caution, as Dr. Wailal also mentioned, when it comes to reporting results of surveys or cross-sectional. It isn't always accurate. It does, however, give you at least an idea. Of course, this is a complex issue, suicide. There is probably lots of cases go unreported as well for various reasons I mentioned, possible cultural, religious, stigma, all sorts of other factors. We would, as a result of this, maybe would like to move forward to a better reporting system, if we can put a reporting system as in place. If we can make this a focus, there may be a better way to report these cases. Of course, all cases will only be reported if they come across or people become aware of them. And if there is post-mortem is being done or there is any investigation being done. In most cases, families of an individual who have completed suicide, they probably wouldn't want that to be public or would want it to be investigated. So it might go unreported as well. But for those who end up being well reported and well investigated and as a complete suicide, of course, if there is a reporting system in place to have much better accuracy, that would be the way to go, definitely.
Great point, Dr. Nadeem. And I see Abdul Karim has a comment. Just a kind reminder to keep the comments under 2 minutes, please, so we have time for the rest of the discussion. Please.
Okay. Thanks, Dina. Actually, I will not take a long time, but what I'd like to return back to the substance disorder, because actually this is one of the main problems we faced in whole Syria, actually. And actually what's happening here, we diagnosed the relative very well, but still in the intervention, we didn't do much effort in this disorder actually. Yeah, we have WHO manuals, but from my experience, all these manuals or the evidence base for these manuals, it's related with reducing the distress more than dealing with the substance itself. The most effective approach that I found it, what we call the brief intervention for substance, which is fine, good, and actually, but it's not the maximum thing we like or the maximum thing we can think about it. Yeah, there is a lot of programs, but still the implementing of these programs inside the Syria, it's very low, especially for substance. Actually, the aim of my talking is try to push the attention that we need more research in the intervention side. We need more techniques to dealing with this problem. Actually, we need to get out from only diagnosis what's happening, which is good, which is very essential part, but actually we need to push the car to move step forward, only to try to save the people as much as we can. Until now, all the manuals or the interventions, it's still there inside the area. I don't know, I hope in the technical working group, we can do something related on that, but actually from my experience, we have a lot of problems and a lot of demands, usually the technical working group for Syria dealing with it. And there is also another major challenging, because the study says 89% of the people they addicted, they return back to addicted again. And this is what pushed us to thinking about we need multidisciplinary approach to deal with this problem. Because if we deal it in pharmacological way, it's fine, but actually it will not be the result. So we need to have the medication with the psychosocial support, with the family support, with the family parenting skills, all these issues, we need to gather all of them in one approach to deliver to the clients. Thanks, that's all of my side.
Thank you very much. And we really appreciate a number of you drawing on your field experience and highlighting some of the concerns regarding data and the quality of data on these issues. Speaking of which, we have Bashir Al-Haj Hussein, who I believe is based in the field as well. And I'd welcome you to comment on this topic. Bashir, I see your hand is raised.
Yeah, sorry. Good evening, everybody. I'm sorry I joined late because of some misunderstanding of the time differences. I'm sorry. I will jump in directly. I'm Bashir, and we are working for cross-boarding response for mental health and psychosocial support, and we have the platform of MHPSS Technical Working Group. I will start by suicide by saying that the whole thing started for suicide. I mean, we start to highlight and focus on the whole situation of self-harm and suicide situation in northwest of Syria in 2018, when if you remember, guys, the unfortunate act when one of our colleague, a humanitarian aid worker, she ended her life by jumping from a high building. It was really a stunning situation back then, and we started to focus on this situation, and we started by the humanitarian aid workers, what kind of stress and problems and issues, burnout or secondary trauma or whatever compassion fatigue they might face in the field. And then we moved to try to understand the situation in general between community members regarding suicide and self-harm situation. And yeah, as my colleague Salah mentioned, we have conducted a survey. It covered back then 12 months between 2019 and 2020 in northwest of Syria, and the sample was 600 health workers and some other humanitarian aid workers working in protection and MHPSS field. Well, I still remember I have phrased the figures or the results of this survey when I have presented these results in the health cluster, one of the health cluster meetings. I still remember that every 72 hours, we had 7 suicidal attempts. 2 of them were successful. Maybe it looks, a catastrophic situation, and still the numbers, I believe, it doesn't reflect the real situation of self-harm and suicide in the northwest of Syria. Also, as my colleague Salah mentioned, there were some duplications, and also when you try to do some surveys regarding suicide, the real sample, the victims, I would say, they are not there. You should ask somebody else, a humanitarian aid worker, a family member, or whatever other relatives. So the credibility here should be more strict to have real reflective numbers. But still, on the other hand, I believe the numbers are higher than that. In this regard, by the way, it's not only about suicide and self-harm. There's a big lack of more solid research and studies to screen the spread of all of mental health disorders. This gap is still there. We're still relying on, until as I'm speaking, we're still relying on some secondary data published by UN agencies, and it's not directly related to mental health. It's mostly it's about, let's say, social or protection issues, domestic violence, gender-based violence, or whatever other, I would say, non-mental health related issues. And this actually might mislead the understanding of the situation, and also sometimes because there are some common mistakes between community members, even between humanitarian aid workers, about Syrians. And based on our database as MHPSS implementers since now 8 years, believe me, guys, the numbers are telling something different than people what might or would think. For example, I still remember the survey we have done, we have conducted in 2015. It was, we have used SCL or symptoms checklist. It was a diagnostic, let's say tool to screen a sample of 2,000 Syrians inside northwest of Syria. We were trying to understand more the spread of mental health disorders in particular. And I still remember the figures that 6% of the sample or individuals have developed PTSD, for example. When people think that all of Syrians, they have been traumatized, okay, but not all of them, or not the majority of them, develop PTSD, for instance. Or some other research I still remember being conducted by other partners, like the results, I don't know if they are reliable, like 70% of Syrians developing major depression, like 60% of Syrians developed anxiety at some level, or anxiety spectrum, whatever, phobics and other things. I don't think so, because I'm not saying this I'm not making this up. I'm now speaking of our own database. Believe me, the numbers, when we are talking about mental health disorders as diagnosed disorders with specific criteria, no, I don't mean, on the other hand, that there are no mental health disorders or they are not spread between Syrians, but not in the way people think of. People are resilient.
Bashir, I can't hear you anymore. Can anyone else hear him? Okay.
No, actually, we lost him also.
All right. Well, thank you so much, Bashir. I will move on to our panelists, but we can come back to you. And thank you so much for your important comments. Dr. Andres, over to you.
Hello, this is Andres Barquilla, Syrian psychiatrist, worked in the region for a few years. Thank you for the for putting together the conference, seeing all familiar faces. I mean, so many points to comment on. I'm just gonna keep it brief, and then we could expand on any of the points that people will think would be interesting. First, I do see from the initial discussions about the conference, the focus on substance use and self-harm. Very timely, these issues tend to be under-addressed in terms of policy and health services. We've seen more focus on substance use lately. And this is, having worked in the field, this is tend to be because NGOs think usually these two issues belong to the governing authorities, whatever the authorities on the ground are. So they are actively not interested in addressing them. Things are changing, but this is kind of explain why these tend to be kind of an orphan causes. And in line with the public health network, among all the mental health issues, these substance use and self-harm do have a huge public health concern. In terms of self-harm, as we heard, people who are precariously housed could have more self-harm tendencies. Substance abuse, we think about it in terms of availability of the substances, governing bodies, police, and what's going on. So it would be great if we could kind of expand on this view on mental health from a public health perspective, because often we talk about these issues in terms of clinical issues, which is important, but missing. In terms of self-harm, of course, multifactorial issue, as we heard from all the panelists. It will be interesting, I think, to see what could be our focus. Like, where could be, if we can address one thing, is it location? So people, maybe more services in camps versus outside camps. Is it age groups? What Dr. Mishmish was talking about, I think it's super interesting. The adolescents, maybe this is where our focus should be. We have an intervention, as we heard from Dr. Khani. So like we have the issue, we have intervention, maybe linking them together, because it is true that it'll be hard even in developing countries to address suicide in general, but maybe we could address one aspect where we could actually have an impact. We're not going to house people, but maybe we could have family intervention or something like this. Dr. Abdul Karim mentioned training. Trainings, this is something I'm very interested in. We did a survey a couple of years ago about training capacity in Syria, Northwest, Northeast, and basically what people told us, there's a lot of one-on-one training, there's a lot of psychosocial support training, but it's not enough. And unfortunately there's a kind of diverging forces in the field where more and more push towards more basic training, even self-help training, which I understand, because you don't have specialists, and this tends to kind of go with a humanitarian perspective, try to reach the most amount of people, the most shortest time possible with the least resources. But now in Syria, we are not just a humanitarian context. So this is also, it has to be seen as a development context in the sense, we can't just keep doing the 101 training. We need to invest resources in training people at the 201, 301 level, where not everyone can have mental health first aid or self-help, although they are very important, but also can we develop a cadre of specialists who will be able to address issues like substance abuse or self-harm. Also, he mentioned, I think, which is very important, the issue, a lot of the WHO training usually is related to stress. And even with substances, there's a focus on alcohol. I reviewed the project, the grant project for this project between Ukraine and Uganda about alcohol. And, my feedback was, if you look at the substance in Uganda, there is very little alcohol, but there's a lot of, it's like the Syrian context, a lot of pills and something like the Captagon. So is this the same intervention? Do we need to have interventions that are not alcohol-based, but more like related to substances that we see in the Syrian context? It could be the same. It's just like something to think about. And finally, the issue of the 70% PTSD, we've dealt with it for a long time, always trying to explain it. I think I agree with everyone else. Not everyone is. It has a bit of and this is something we discussed a few times when I worked with MSF. It has a bit of a media effect to it. I think NGOs like to present these numbers. It's good for donations, and donations bring money for the programs, I understand. But at the same time, I think it traumatizes and kind of pigeonhole everyone into this vulnerability mode. Oh, poor Syrians, all PTSD, and it's not, and it's also not correct, because I think what ended up happening is they use the public health questionnaires that shows vulnerability, but it doesn't. It's not a clinical diagnosis. So if you think vulnerability because they ask the 3 questions, it's clear that yes, people are vulnerable, but that's very different from saying that they have a clinical diagnosis. And I think that tends to be a huge issue. And finally, to Dr. I'm sorry, name. I will remember the name. The person who commented on this is a Syrian conference led by Syrians, which I think it's nice to see. Now with Samah, we had when I participated with them, we had a few conferences led by Syrians. So this is not new, but definitely we need more of it, because Dr. Abu Hilal, I'm sorry, Dr. Abu Hilal mentioned it. Because the type of conversations we used to have in these conferences are different from what you have when you have more of a kind of a expert-driven but not related to the region conference. Thank you.
Excellent points all around, Dr. Andres. Thank you very much. And especially the point on sensationalizing mental health, I think, inside Syria, which has been an issue for the last decade, and ways we can think about approaching it more holistically and sensitively. And I think you also mentioned funding. So hopefully at some point we can discuss very briefly some opportunities for increasing funding, given that there are so many different avenues in which we could approach this issue and different populations and geographies, as you mentioned. So if we can discuss funding also briefly, that would be wonderful. But first, I'll turn over to Dr. Muhammad Abu Saleh.
Oh, thank you, Diana. I just have got in front of me here the WHO EMRU report 2017, which is quite a sobering reading for me, because I didn't realize how much provision there for mental health and psychosocial support in Syria. I learned that the WHO set up a psychiatric unit in general hospitals in Damascus, Hama, and Latakia, and also, importantly, has trained over 1,000 GPs in mental health gap and 2,000 health workers with the same, and supported 150 primary care, secondary care centers, health centers in 11 governorates. I suppose the message here, as I mentioned in my talk, and I'm delighted that Peter Hughes has joined us, because I really want to emphasize that first we need to have numbers, etc. But I should tell you, the WHO EMRU office painstakingly tried to collect data from all the 22 countries of the EMRU region on substance use, be it alcohol or drugs or suicidal behavior, topics that are we discussing here, to no little response. So whatever the size of the problem, it really doesn't matter. What matters is that they exist and they are here and they're with us in Syria, in all where Syrians are in neighboring countries or in Europe. What can we do for them? To me, it's quite simple. The mental health gap is an absolute universal standard applied in 100 different countries in terms of enabling non-specialists to assess competently and diagnose mental disorders that include, of course, the substance use. It's got a module on drug use, a module on alcohol use, and also a module on self-harm. If we can train all these non-specialists or GPs, then we've done a great amount of work. But plus also the interventions, the problem management plus, self-help plus, and other things that might emerge and so forth. So if we could do that, then we really can deal with a lot of these problems when they emerge in terms of screening, identification, and appropriate interventions. For substance use, if it's not so severe or dependence, then we can use brief interventions, a couple of sessions. Using motivation interviewing is highly effective. Where it's established, there are recognized evidence-based treatments, pharmacological and psychosocial, tried and tested, and they apply to Syrians as well as to any other. May I just, if I ask Peter Hughes to comment, because of his vast experience in having trained thousands probably of non-specialists and also has experienced in terms of the impact and effectiveness of the mental health gap program.
Thank you, Dr. Mohammed. Yes, Peter, if you're with us, it would be great to hear from you about MHGAP.
He's muted, but
we can give him a moment. And
okay.
thank you, Dr. Mohammed, for emphasizing MHGAP, which is evidence-based, low cost for implementation, and can resolve the issue of the lack of specialists currently existing inside Syria, as well as other contexts. I think on that note, something that perhaps MHGAP does not incorporate, and I know was mentioned by Dr. Abu al-Hilal briefly, is the role of faith and religion. And Ola had a question in the chat about raising awareness about mental health and psychosocial support, given that we know there's a lot of cultural stigma specifically surrounding issues of substance abuse and self-harm. So I would like to open it up in case our colleagues in the field have any perspectives or thoughts on the role of religious leaders and faith leaders. Oh, please, Dr. Abu Hilal. Oh, yes.
Sorry.
Let's start with Dr. Abu Hilal.
Okay. Yeah, actually, I think we can put it under the umbrella of cultural adaptation for all the interventions and also localization. So this is something is missing in all the humanitarian programming, and especially in mental health and protection. So we need to learn about the culture, the needs, and the voices of people actually when programming. So one of these is engaging faith leaders. And actually, maybe in our context is like very sensitive issue to have, because all this about like terrorism and Islam and all this is sometimes make organization reluctant actually to engage with faith leaders. However, it is as ISC guidelines, it is very important to engage with faith leaders and community on different issues, including mental health. So I think we need to include them and increase our capacity actually to include these people. And there was many initiatives actually that trained some religious leaders on mental health, and it was very good outcomes actually. They are listening, they are interested. So I think this is an important point that we need to work on. Thank you.
Thank you, Dr. Abu Hilal. I will hand it over to Dr. Nadeem, who I believe had a comment.
Yeah, I think this is an area that, it could go either way, because sometimes there can be a hindrance. Religious enough, maybe, or talk about jinn and various other explanations that can be provided, which if they can, if they carry on talking about it that way, they might just make our mission even more complicated. So getting them on board is important if we can find a way. If we have to, but you don't have to. If we have to, say, if we're going for an intervention like family intervention or any kind of reporting issues, and that we need to engage the local community. So using community leaders or maybe religious leaders in a mosque or something to highlight the issue, or maybe make the people aware of that there is a mission around, for people to come across. I remember when I first went to refugee camps in Turkey, that was February 2012. The refugees were only about 12,000 Syrian refugees altogether at the time. And they were obviously in various smaller refugees, 2,000 each. And they had a center, or some of them had a kind of makeshift mosque. So I went along with a colleague, Dr. Khalid Sultan, So we went there. So we obviously, it's lots of people. We didn't know how to help. So we've asked the community leader and also the sheikh in the mosque to try and make people aware that we were there to help, and that people shouldn't shy away from asking for help. And then we had a separate room, and then all of a sudden we have a flood of people, queue of people who wanted to speak to us. So you could somehow use their expertise in terms of their leadership in the community to highlight the issue of mental health, and that if people want to seek help, to come forward. But you need to be careful that sometimes themselves can complicate the issues as well. So
thank you for pointing out that nuance, Dr. Nadim. I'm going to steer us away slightly from this topic, since we only have about 8 minutes left for the discussion before closing remarks. So appreciate your flexibility. Eleanor had a question about law enforcement agencies playing a role in drug and substance misuse strategies and what this looks like in Northwest Syria. Excellent question. I'll keep it open for those who want to respond.
Dr. Abu Hilal probably is the best to answer the question.
Sorry, can you repeat the question, please?
Yes, of course. So in the UK and the US, law enforcement agencies play a large role in drug and substance misuse strategies, so policing. How much of a role do these agencies, such as law enforcement, play in Northwest Syria?
Yeah, I don't think that I'm the best one. Maybe Dr. Nidal, if he's here, can. But I think this is complicated in North. So there's different authorities in different areas, and also sometimes there is a lot of dynamics in there. So I think this is could be one of the causes that till now we didn't have any centers that can be providing this. Even if you want to have like a private center for that, it could be like risky, right? So I think this again take us to the main point that I'm emphasizing. We need to engage as many stakeholders, wider stakeholders on this as we can. And I think this is need a collective efforts. Actually, it is complicated. I want to comment on what Dr. Muhammad Abu Saleh said. I'm sorry, but if they opened a lot of like treatment centers, but still there's a lot of production of drugs itself in Syria, right? So this is, and this become like a global pandemic that Syrians are shifting or sending drugs, right? So it is like a very complex and big issue. This is mine. Thank you.
Thank you, Dr. Abu Hilal. I understand this is a difficult conversation and delves into more of the local authorities. So thank you for attempting to answer. There's an important point from Hareen about being a foreigner working on a Syrian response, and specifically being aware of the cultural appropriateness of tailoring mental health responses. So the question is, or rather the comment is, that Syria is moving into the developmental phase now. How do the panelists see mental health and substance misuse issues being addressed in a culturally appropriate way, using Syrian experts and pushing humanitarian actors to concentrate on this aspect of health? And I think we have good representation here from those who are part of the mental health working group who've already commented, but I'll keep it open for those who want to respond, and this will probably be our last question.
I think I can just give a quick comment, though not necessarily provide the full answer. The fact that the situation in Syria is still ongoing, the conflict is still unresolved, and obviously the ever deteriorating economic situation in Syria put people on all sorts of difficult kind of situations. So you would think, as a result of that, there is lots of unemployment, lots of anger in people. There is possible domestic violence, all sorts of other possible mental health problems, anxiety, depression, PTSD, or whatnot. Although I don't necessarily agree on figures being given in studies, but you would think there are lots of problems. Of course, the self-harm and suicide is probably the most serious because it's black and white. You could just end your life or not. Whereas many other mental health problems, there's at least a room for improvement, a room to treat. Whereas suicide, that's it, cut-off point. So it is quite complex to try and, given the context of what's happening in Syria, to try and focus on one area on top of the other, and how we can raise, this issue to a point where people, can start taking it more seriously to put something in place to remedy the situation is a huge task, particularly given the rarity of suicide. Yes, every loss is a huge to the family, to the community, but it's still thankfully a rare incident, suicide. And Syria, as I mentioned in my presentation, come the lowest of the last 10 countries in terms of rate of suicide per capita. So to push people, or particularly external donors or not, to focus on this, given the fact that the loss of other areas that might also take precedence on top of this is a task. However, self-harm is obviously more endemic than suicide. It's much more prevalent, much more common, particularly in young population, and making sure that we try, we put systems in place, particularly at school or maybe primary health centers, to ask the question, particularly for those who might appear as though they're struggling or they are in distress, at least to ask the question about suicide or suicidal behavior. And by asking the question, we identify the case, and then hopefully it can be taken from there to be reported. Of course, lack of resources and personnel and that are experts in mental health in Syria is a problem, despite the big efforts of the mental health gap program to try and raise awareness and educate people in primary care. There still isn't enough resources when it comes to mental health professionals who might provide the right support and help when it comes to it, when it comes to therapy or individual intervention. So there is that shortage in terms of personnel who might be able to help. So if you look at the whole picture, it's quite complicated. And mental health, as it's normally the case in most countries, not just in the developing countries, it doesn't take priority as much, sadly, let alone in a place where it's still in the middle of a conflict, unresolved conflict. So it is a task for all of us to try and drive this forward and hopefully find a way to manage. But as Prof. Saleh said, the task is huge, but there is always something that we can provide, even if it is little. If you're not able to solve the whole issue in one go, at least let's focus on what might work, even if we can help a small number of people. And I think Alal Al-Khani, thanks for mentioning the family intervention. But there are other things that can be put in place, at least to help some parts, until we become in a better position where we have more resources, more personnel, more trained personnel to overcome the whole problem. Yes, we don't want to try and carry on cursing the dark, as Tagore said, when we can lighten a candle. So that's, let's focus maybe on, even if it's small steps that we can take until we are in a better position to solve the whole situation. I hope I've just contributed to answering this question, although it's not maybe the answer that the one who asked the question maybe was hoping for, but
thank you, Dr. Nadeem. That was excellent, actually, and a good note to end on. And I hate to do this because I know Dr. Muhammad and Bashir, you have valuable comments to add, but I am aware of time. So I think we might leave it there, and I will hand it over to my colleague, Dr. Fuad, to wrap up the discussion. And thank you all again for the panelists and the speakers for your important contributions, and hope to continue this conversation.
Thank you, Diana. Thanks a lot. And I really want to thank Dr. Abu Hilal, Dr. Al-Mishmush, Dr. Abu Saleh, Dr. Al-Khani, and all the panelists for this really, I mean, amazing, fabulous. I can describe it actually for all these adjectives, you know. When we start thinking at you know, Syrian Public Health Network and at R4HSSS about thinking about, you know, the topic of this workshop and having, you know, mental health at the beginning in mind, and then we thought that, well, let's go, you know, deeper. Let's go with, you know, more specific issues, and we thought about, you know, self-harm and drug abuse. To be honest, it went beyond our expectations. Having all this rich discussion and conversation and presentation, and you know, it was clear and still clear that the needs is, as Dr. Abu Saleh mentioned, the task is a huge. You know, there are a lot of issues that should be done, and you know, research is something definitely important. Talking about, you know, trust of, you know, in data, you know, still there are huge gaps of the issue of data about, you know, these very sensitive topics. You know, services, what sort of services, you know, beside the, you know, one of the great intervention by Dr. Khani, what are other services that can be implemented in such a context? You know, the issue of training, you know, that's raised in the conversation, the advocacy, you know, funding. So, I mean, definitely, you know, we're still in the beginning of this long pathway. So I'm sure this is not the end. You know, we hope that we just open the door for more discussion. I don't know. Usually, we have a sort of a brief, you know, sort of, I don't know, writing something, a piece on from the workshop, from the discussion. But I do believe that we need more than, you know, just writing a paper and putting it in one of the journals. I think there's a need to have a collective work together. Maybe I would, you know, encourage us as organizers for this to keep receiving comments, keep receiving any thoughts, any ideas about the topic, and try to translate that into, you know, even more research, you know, developing services, advocate for that. I mean, we need to find a way to push toward, you know, more comprehensive approach of this topic. I also should thank Karim, Diana, Ola, and also, you know, from the beginning, Andres contribute in the on organizing, you know, this workshop. And thank you all for your contribution. I see the list actually of participants that even they didn't find time to contribute. Huge, a lot of experts there. I mean, very rich participants. So I wish we could have another opportunity, and hopefully we will find another opportunity to keep this conversation alive. And thank you all. Thanks a lot.
Thank you.
Thank you. Thank you all of you.
Bye-bye.
Bye.